So we've already put out a survey asking for some questions for this part of the talk, and we have an impressive list of panellists for you, ladies and gentlemen. Today we've got Professor Ahmed, who's going to stay around for a bit. We've got Dr. Claire Hill, we've got Kasim, Dr. Javid, we've got Dr. Kira McDonnell, we've got Dr. Susan Parek, Dr. Judith Babir, we have Lisa Mills and Jazz Sahota. We're just delighted you could all join us. And for this session, I'd like to invite my colleague, Corinne Kildare, Support Development Officer, to moderate and channel the questions to the people gathered. So over to you now, Corinne. Thank you.
Okay, well, first lot of questions are COVID related. So I'm not sure, Dr. Schweid, I'll maybe get you to answer some of these, seeing as you've done our previous COVID webinars. And Dr. McDonnell, if you want to maybe add a little bit in about sort of the Irish perspective on where we are. So first question, the Medical Advisory Board previously advised for those with significant scoliosis and deformed chest wall to shield, and were very clear they wouldn't even recommend going for a quiet walk. What is the view now in the context of the change to the government advice? Firstly, that shielders could go for a walk, which happened a couple of days after the last Q&A session we held, and then shielding being paused.
Well, I think the best thing to do is, because the advice is changing and it's not available everywhere. So I think it's really hard to give generic advice, because there are some cities that are in lockdown. So where they're in lockdown, you have to follow that advice, and it's really hard to give general advice. I think if you're not in lockdown, then it's okay to go out, and the self-shielding I think is ended. But for what we're finding, so I can just speak for Oxford, we're on the brink of another spike. So we've actually, following local public health advice, told people within that area to go back to that. I don't know what it's like in Scotland, but we're finding you can't give generic advice anymore, because it really reflects where your local institution is. And always remember, this is just guidance. And I know a lot of people are actually being a lot more restrictive because they want to stay safe. The big issue is with employment, and where their employer is now inviting them back to work. And that is often left with a discussion with your employer, and we can write letters of recommendation. Is that what's happening in Dublin and in Scotland, Faisal?
Yeah.
Kira, go ahead.
Well, I was going to say that at this moment in time, there's no area in Ireland that is in lockdown. We're seeing an increase in cases, but not an increase in hospitalisation. And I think the challenge is on us now to learn how to live with this. So how can we, allow people to live normal lives, or to be out in their communities and be safe? And it's a worry that we might get that wrong. But I am encouraging the children that I am involved in the care of, unless they have respiratory support in morning or night, to go back to school. To go back to school in consultation with their school, wearing masks, with social distancing, and doing the best that they can. But they do rely on those around them as well as their families to make the correct decision. So the guidance is very unique to each individual family setting. And I think, like you said, Kasim, it's very, very hard to know what the right advice is.
Yeah, I agree with Kira as the point she's making, because I don't think necessarily you can get that information from the any public representative, really, because if you look at Glasgow at the moment, Glasgow City is in a kind of a partial lockdown, but Greater Glasgow isn't. So there are parts of Greater Glasgow which isn't. So I think what Kira is mentioning, I think, is very important. That as far as children goes, really is those with substantial respiratory problems are the ones I'd be worried about, but not the others. And I'd really be encouraging everybody else to go to school. As we all know that, I think probably the effects of not going to school are probably much greater than actually staying at the moment and thinking about protecting them. For adults, obviously, it that's a very important point you're making, Kazim, about this kind of feeling that you have to go to work. But I think even that is a partial going to work, and as long as the protective measures are being instituted in the workplaces, I would feel relatively reassured.
Thank you. Along a similar line, the next question is, what would you advise be to adult OIers who have previously been told to shield, but who have children that are now away to start school or have started school? They will lose the ability to manage their own risk and protect their own environment when the children will be attending school each day and then returning to the home with the possibility of being exposed. Is there any advice? I'm not sure who wants to take that, if it be a paediatrician or an adult.
I think that's a really difficult decision to make. I mean, the guidelines are that the shielding has ended, and unless there's a local lockdown, then the children are advised to go to school. It is reassuring, and I think Chris Whitty, the CMO, has said this, that actually the risk of children is lower. It's not the same as adults, and it's a relative unknown whether this return to school will really lead to a spike in adult cases. I actually don't know. Does anybody else have any clear advice? It sounds a bit grey because we actually don't know, and it's going to be based on individual risk. But I think the general advice is kids go.
I agree. I think it's really difficult, isn't it? And we don't know. I think might be interesting to see if any data comes from Scotland, because their children went back to school already, and whether we see any data coming out of there. But yeah, it comes down to individual families. But like Faisal said, the children need to go back to school. So, it's difficult, and we don't know what's best to advise, really.
Yeah, fair enough. Thanks for that. So the next question I've got, it seems many people with OI have a higher temperature than normal. Is this because of our faulty collagen or not related? And could this become an issue with the current temperature checks being done? I don't know who wants to take that. Does somebody want to put their hand up?
Well, maybe this is just my ignorance, but I didn't realize that the temperature was above 38 in people with osteogenesis imperfecta. That's a kind of mark. This is a kind of a rough mark of where the temperature is supposed to be. I think it's possible. It may be in some person, but I think you'd have to feel really hot, perhaps, and dry. Kira.
I would add that, I have quite a big cohort of children with recessive OI, and they have a tendency to sweat a lot. I think they have inherent respiratory issues, and I know that when they have temperature checks, and we're doing a lot more temperature checks on well children, that they are coming in between 37 and 38. And if you have the forehead held thermometers and things like that, they are not as accurate, and they are likely to flag them as higher than they actually are. So that has caused concern with some children here. And I think what we have to do is establish what someone's baseline is when they're well, and then, support them with that. I don't think it's necessarily an OI thing for everybody, but I think that we have to acknowledge that some people do have a higher temperature, some people have a cooler temperature, and those skin thermometers aren't accurate, so it could flag people and make it difficult. But
okay, no, thank you. All right, so the next set of questions are kind of medication related. So the first one, or the first two, are sort of in relation to acid reflux. I guess these are aimed more at the adult consultants. Is acid reflux fairly common in type 3 individuals, especially with kyphoscoliosis, and can this manifest in other issues such as asthma if left untreated? Are OI patients more susceptible to instances of increased bronchial and tracheal secretion, and what type of specialist would initially be best placed to investigate this?
I'm happy to take that one to start off with. So yes, anybody with a kyphoscoliosis is at increased risk of acid reflux because their stomach gets a bit squashed and there's a bit less room, and sometimes the stomach's pushed a little bit up into the chest cavity. So that is the case. And yes, if you get acid reflux, you can get respiratory symptoms. So it's really common to have a cough. And sort of nighttime coughing can be a feature of this as you lie down and you get the reflux, and it can cause cough. So the bit about increased bronchial and tracheal secretions, I think that's probably true, but a bit difficult to tease out in someone with reflux. And the specialist we would probably suggest would be a respiratory consultant, because some of that can be a bit difficult to tease out. You probably want to do some lung function testing as well, to be able to tease out, is it reflux, is it lung disease? And they see quite a few of our patients.
And similarly, I'm taking a Retrosol medication due to acid reflux, but I've read that this can affect bone density. Is this true? And if so, should I reconsider another medication? I don't know.
Shall I take that one, Judith?
Yeah.
Yeah, so that's a very controversial area in people with osteogenesis imperfecta as well as without. I would say at the moment the studies are potentially suggestive, but nothing strong enough to make a clear clinical recommendation. It's a very complicated study to do because you have to look at people who are either given omeprazole or not in a sort of randomized way, and the studies really haven't been long enough to do that. They've tried to address it with other types of study design, but it hasn't really worked. And at the moment, if you need it, you should take it. But if you need it because you're on one of the bone treatments, you should ask for your bone treatment to be changed. So if you're taking alendronate or ozidronate and that's causing symptoms and your GP puts you on omeprazole, then you should ask for that bone treatment to be changed.
All right, thank you. The next two, I might just put to the paediatricians. Can steroid inhalers have a negative impact on bone health?
So everything in moderation is good. Anything in excess is not good, is my general sort of message in life. And it applies to inhaled steroids as well. Inhaled steroids are given for a reason, and they're prescribed to, of course, tackle asthma, which is chronic asthma, which is not controlled by just giving the blue puffer, which is just used for episodic reasons. So as long as it's used within the right amount of dose, I think it's fine. Also, remember, when you take the inhaled steroids, you have to take it in a proper way, which is you've got to take it with, depends on how old you are as a child and so on, and you need to take it with a spacer. Afterwards, it's useful to give the mouth a wash, a little rinse and all that, just to get rid of any excess steroid, which is lining the mouth, and so on. So I think from that point of view, and as long as it's taken in the right dose, it's fine. People have shown that if you give huge amounts of inhaled steroids, then it's not good for you. And from that point of view, it's not just for bones, but it's for other things like growth and your weight and how you tackle stress and so on. So I think, yeah, excessive inhaled steroids is not good. The effect on bone actually is quite small, even in those excess ones who take inhaled steroids to an excess level. It's the other effects on inhaled steroids which are not so good. Kira, is that right?
Yeah, I would totally agree with Faisal. And I would also add that, I think you're trying to take things out individually. Inhaled steroids might cause you issues if you're also taking oral steroids, if you're also taking supplements or herbal remedies that contain steroids, and that's where you're more likely to have issue. And to add what everyone else has said about medications in general, I think what's the most important thing when you're using inhaled steroids is that you try and increase and decrease the dose as compared to the season or to your overall needs. Like if you've had a run of illness, then it might be of benefit to have inhaled steroids for a period of time, but then you should be trying to reduce it to see what the lowest possible dose you can have is. And that should be the same for any medication. So.
Okay, thank you. So next question, how common are atypical femur fractures with long-term use of bisphosphonates such as pimidronate? Are you at greater risk of femur fracture happening again upon restarting treatment? I don't know. pediatrician?
So in children, I don't think I've ever seen one. But adults, I'll leave it to my adult colleagues.
So I agree with Faisal. I think that the important thing here is actually the femur shape of individuals with OI is slightly different. And actually you can get fractures that look like these atypical fractures, but there's been a nice study from the Montreal group that have shown that the pattern of these fractures hasn't changed really between pre-bisphosphonate and post-bisphosphonate. And actually they can find as many people with these what we're calling atypical femur fractures without bisphosphonate as with. So I think it's a confusion in the medical field as well, that every time they see this type of fracture, they say, oh, it has to be the drug. But actually there are quite a few people who are having these without the drug, and they tend to be the more severely affected as well, which makes it even more complicated to tease apart the effect of the drug and the illness.
Okay, good. So this next question, which we should maybe have had Dr. Lanham, you on the line again today. Maybe just get a yes/no answer from each of you. Do supplements, i.e. turmeric and black pepper or fish oils, help with aching bones?
I would say no, because fish oils have variable amounts of vitamin D. Avoid taking fish, and actually there's lots of other stuff in fish oils. So I think there are lots of vitamin D preparations that are available that don't have fish oils and are easier to take and taste a lot better, actually.
Okay, fair enough. So the next set of questions I have are dental related. Hi, Dr. Preck, I'll aim these at you. Do you have any advice for how best to access good dental advice and treatment for OI patients? My dentist is fearful of undertaking work such as implants and bridges, as I have mild OI. I don't have dental stenosis. Is there any evidence that dental surgery is especially problematic in mild OI?
Okay, so I guess I need to start off by saying I'm a pediatric dentist, so I don't have any knowledge of sort of implants or sort of advanced work for adults. But I think I would say if you are trying to get, as an adult, I know trying to get access to a good dentist for OI patients is really problematic. What I would normally advise is if you can get in touch with the OI centre, they all have a pediatric dentist attached to them, and they may be able to sort of recommend colleagues, if particularly they're all attached to dental hospitals. So there may be sort of adult colleagues in the restorative departments and prosthodontic departments who may have a special interest in OI patients, and they may be the sort of person they could recommend your dentist referring to. So for example, I have quite a few patients from Stanmore where they'll contact me and say, we've got a patient who needs quite a few dental sort of procedures, and then I can recommend colleagues at the hospital where I work who I think would be a good person for them to be recommended to and referred to. So that's what I would say for that first bit. The next bit of the question was, obviously, is there any evidence that dental surgery is especially problematic in mild OI? The reality is that, so for most dentists, the worry they have with OI is if a patient is on bisphosphonates. That's one issue. And then the other issue is if they have dentinogenesis imperfecta as well. In terms of bisphosphonates, certainly I know for children, there are no sort of recorded cases of any issues regarding following extractions or surgery for children who've been on bisphosphonates. So there shouldn't be any sort of issue for that. For adults, again, I'm not aware of any issues, but I know that if adults have been, children have been on bisphosphonates, there's always a concern of what the healing is going to be like post sort of surgery, whether that's for implants, for extractions, orthodontic surgery or anything. And again, I think it has to be a case of, it will be an individual assessment for that person, as in how long they've been on bisphosphonates, what is their bone health, what is their gingival health, their oral health, and what is suitable for them. In terms of sort of orthodontic treatment, which is another thing I get asked quite a lot, again, there are no sort of studies showing that it can't be done. It probably takes a little bit longer because bone's a bit thicker, it's a moving teeth, and it's mostly case studies, but there doesn't seem to be contraindication for having that done.
Okay, thank you. I will ask the other question. I'm aware we've only got 10 minutes left and I still have quite a lot of questions.
Okay, I'll be quick.
Do you have any experience of fillings causing further breaks in teeth, and any approaches or materials that might help to avoid this?
Again, I think that depends on whether you have DI or not. If you have got DI, there are definitely issues of bonding. So sort of white fillings or anything adhesive, there's a high risk that it's going to fail. And for those patients, certainly for children, we would consider putting a crown over that tooth rather than a filling, because we know that it's going to protect the whole tooth. If you don't have DI, then depending on how the teeth are, there shouldn't be any issue with having sort of normal adhesive restorations. But again, if there's any issue, we would normally go for a crown to protect the whole tooth.
Oh, great, thank you. So the next couple of questions I've got are school related. So maybe I think if I can put these to Claire and Lisa, and Jas, if you want to add anything to these, feel free. So this was from a nursery school. We have a child with mild OI who wants to get stuck into everything. They're struggling to understand they can't do everything that their peers can. How can we overcome this? Don't know. Claire, do you want to take that first?
I can lead on that if you like. I think probably early on it's getting a balance of education with regards to the fact that their bones are slightly different, more brittle, and therefore, excuse me, they are more likely to have a fracture. But alongside that, getting children to understand that exercise and activity is really, really important. So we don't want them not to do anything. So it's getting that nice balance. And what we always try and suggest is trying to lead them down exercises and activities that are actually more suitable. So things like swimming, badminton, table tennis, dancing, potentially if they're really mild, we have quite a few of our mild children who cycle quite a bit, or things like archery, and trying to encourage them into those sort of activities rather than the contact sports and the impact.
Absolutely, I think I would agree with Claire. In terms of the nursery school, it might be just chatting with them about the specific things that the child's wanting to get into. Is it like playground equipment and things like that? In which case, depending on the child, in terms of it says mild OI, but in terms of the fractures that they had or whether they haven't had any fractures, and what their motor skills are like in terms of what they might be able to access or what they can start to do, and looking at modifications such as if there's real simple stuff like stepping stones, could they do that but with no other children involved? So I would be having kind of a conversation with the nursery around the types of activities that they're struggling to redirect them from, really, and maybe their local therapist could perhaps support with that a little bit.
Thank you.
To add to Claire and Lisa, I completely agree. I think it's really important that we recognise children with disabilities can be excluded often at school, and that can lead to emotional wellbeing problems with low self-esteem, anxiety, and depression. I think the really important message here is to ensure that you are communicating with your OI team to help support the school and your child as well. There are some conversations a specialist nurse can help with, so doing some education sessions with your child as well. That's really important. And there are obviously some resources on the Brittle Bone Society as well.
Thank you, ladies. And the next one, I'm struggling to get the school to include my son in PE lessons. What can you suggest? I don't know. Claire, do you want to maybe take that one?
I can do. I certainly suggest you get your physiotherapist, either local or specialist team involved. We do a lot of education, and during COVID we've been doing an awful lot of virtual stuff with schools, nurseries, and then kids moving into secondary school. Getting them to, I mean, it's hard with that question to know what the severity of OI is, and often we need to have a discussion with the family about that prior to having the conversation with school. But getting schools to realise that it's really important that they participate and making reasonable adjustments, but just avoiding maybe contact sports or impact type activities such as trampolining. Some of our primary schools, we ask the the school teachers to actually include some of the OI child's activities and exercises that they've had from physio, maybe in the warm-up and cool-down sections of PE, so that everybody is doing those, either stretches or whatever, strengthening type core stuff. But yeah, it's making schools aware that they have to participate and that exercise is really important.
Absolutely, inclusion is really important. We can't just say this children can't be included, and you know, the OI centres, we all give the message that actually PE should and can be modified for all children, and we would really encourage that, and that we will support that as much as possible, doing skill sections rather than full contact, and modifying activities, etc. So I think that's something, yeah, we would all advocate. Absolutely. Contact your local team.
Thank you. Okay, so I think this next question, I'm just looking, some of these were maybe answered yesterday, I think, on some of the webinars. The next one I'll ask, and again, I think I'll aim this at the adult consultants. What sort of routine monitoring or testing would you recommend for a type 3 adult with kyphoscoliosis and obstructive lung disease? My main fear remains that the kyphoscoliosis could progress and we may see a decline in lung function that will eventually place additional strain on my heart. I've struggled with gas exchange element of lung tests previously, so was told to self-report any breathing issues instead of routine monitoring, but that sounds more reactive than preventative. Would regular annual or biannual pulmonary function tests alongside occasional echocardiograms be advisable? I don't know. Professor Shabida, Dr. Kabir, do you want to take that one?
That's almost a respiratory question. I think if someone has, you know, if someone's had lung function tests before, that does sort of imply that they've been under respiratory care, and that sort of fine detail of how often and what lung function testing can be done is something I would rely on my respiratory colleagues to know. I totally agree that ideally you'd want to be proactively looking for problems before they arise. In terms of echocardiograms, again, that would be something that, you know, would not be more than once a year, but it depends, you know, it depends on what your baseline echocardiogram looks like. If it's all perfectly normal, then you might not do that very often. Kaz, do you want to?
Yeah, I mean, I completely agree. The respiratory issues around the shape of your lungs and whether anything needs to be done while you're sleeping, and that does vary by how your chest wall is. For the echocardiogram issue, there is some data from Bente Langerhan's research that shows around 40 there is seen to be an increased risk of some valve problems, and usually this can be heard with a stethoscope. But and it's not quite clear if we find it, what do we do, and how we follow up, because it will be first diagnosing that there is a problem and then leaving it for the cardiologists. And in our experience, we've started to do it, but actually just generate a lot of extra work, and we haven't actually seen it change treatment. It just is just a watch and wait policy, really.
Yeah.
But that's an area of research that still needs to be worked out in adults. When's the best time to screen, and then what are they looking out in terms of who's going to need a treatment because they've got a valve problem versus just watch and wait.
No, I totally agree on the echocardiograms. It's not clear at the moment when we should be doing them. We've started doing them, and our paediatric colleagues have started doing them at transition so patients have sort of had one at about 17, 18, but then when do you do it again? We don't know.
Great. I think we're really running out of time here, so I'm going to ask one more question, and I think possibly Claire, you might be able to answer this one, or Dr. McDonald. What is the current situation regarding elective orthopaedic surgeries in the UK for children travelling from Ireland?
I can talk to the general situation regarding travelling. I'm not sure what's happening at the UK end. Claire, have you anybody travelling?
We have some patients coming over from Ireland, yeah, some for surgery and then others just for treatment, yeah.
So go on, Claire, sorry.
We're tending to get people to quarantine for 14 days before they come, and then they're tested on arrival at the hospital. I wasn't quite sure if this was a COVID-related question or a Brexit-related question.
Can I just say in general now we now have our Centre for Rare Paediatric Bone Diseases up and running. We have the expert MDT team available in Dublin. We have an orthopaedic colleague who specialises in surgery for rare skeletal disorders. And we are taking on most, if not all, of the up and coming patients who need surgery. There is a group that still travel to the UK and they're very confident and comfortable in who they're attending. We wouldn't ask them to move back unless they wanted to. But we would be hopeful that we'll be able to address a lot of the surgical requirements of our paediatric and adolescents going forward in Ireland now compared to previously where they didn't have that option.
Great. Thank you very much, guys.